Good afternoon. I would be speaking on intervention radiology from role in curative and palliative care. So, the spectrum which I would be covering for the curative and would be broadly divided into vascular and non-vascular. In vascular, it would be angioembolization. Angioembolization could be emergency, either a pre-operative, that is definitive embolization, vascular malformations in the mediastinum, lymphangiography predominantly post procedure when there is chylous pleural effusion, when doing a mediastinal lymph node sampling, thrombolysis and thrombectomy for pulmonary thromboembolism, which can include mechanical thrombectomy as well. Bronchial artery embolization when the patient is having a massive hemoptysis, that is when bronchial artery embolization comes into play. Coming on to non-vascular, which could be image-guided biopsies and FNACs, which we have heard. Coming on to the drainage in post-operative setting, whenever there is empyema or the esophagectomy leak, that is the time when drainage needs to be done. Ablations, the heat-based ablation, the thermal ablation and non-thermal ablation. So radiofrequency ablation, microwave ablation, cryoablation, and irreversible electroporation. Foreign body retrieval when the PICC line or the port is kept for a longer time and it gets dismantled and goes into the pulmonary circulation, and wire localization. So, in palliative settings, it would be angioembolization again in case of emergency settings when patient is having massive hemoptysis, IVC filter placement when there is pulmonary as well as lower limb DVT, catheter tunnel placement, thrombolysis, aspiration, and other thing is vertebroplasty when patient is having bony metastasis in a palliative settings, and a pleurax insertion when patient is having significant pleural effusion in the end of life procedure. So coming on to the vascular procedures, pulmonary thromboembolism, this was a 50-year-old patient having a pulmonary artery pseudoaneurysm, and he presented to us with massive hemoptysis, and what do we see? This is a pseudoaneurysm, and we did a coiling and a glue embolization, and on table patient had rupture of this pseudoaneurysm and had massive hemoptysis. We glued it and then patient is all right, and this is post-op, post-procedure. What we can see here is post-op, there is complete occlusion of this pseudoaneurysm which was seen earlier, and this patient is saved. Coming on to bronchial artery embolization, when patient is having massive hemoptysis in case of carcinoma of lung, whether it would be a palliative intent or a curative intent, the techniques and the method remain same. We always embolize that with the help of polyvinyl alcohol particles. So what we see, this is mass and this is embolization which is carried out. We see multiple tortuous vessels which are arising from the bronchial artery on the right side, and this is what I would need to highlight to my radiology colleagues. This is the anterior spinal artery which is seen, and whenever we see this vessel, we do not embolize because that can lead to paraparesis and paraplegia. Whenever there is arteriovenous malformation in the mass which is there, and that is when we can either do a plug or glue or anything. So coming on to the preoperative embolization, either it can be done for most or commonly for solitary fibrous tumor. This is a large mass which is in the occupying the left hemithorax, and that is when embolization has been carried out, and post embolization what we see is very less vascularity. This is the vascularity pre-procedure, and this is a vascularity post-procedure. There is no vascularity which whatsoever, and just what we see is the surgeons have a good field of vision, and the blood loss is minimal. The transfusion hazards are very negligible as compared to not doing the procedure. Whenever there is a lower limb DVT with a pulmonary thromboembolism, this is what the filter, we place a filter into the IV IVC, so that the lower limb DVT, the thrombus does not migrate into the pulmonary circulation. And this is most common when patient is on chemotherapy, because they are in hypercoagulable state, and that is where this is a thrombus in the lower limb, both the sides, and this is how the filter is placed, so that all the thrombus gets captured into this mesh kind of a thing, that is a IVC filter. So many times we are doing a filter for the pre-surgical planning, and that's where the filter needs to be out, because the risk factors have been gone, and this is when the filter needs to be retrieved after placement. If it is a palliative setting, it can be kept into the patient's body. And coming on to some of the other features, when the patient is having CA lung with orthopnea, facial puffiness, and the facial swelling, there is an invasion into the SVC. That is when SVC thrombolysis can be carried out. So this is what we see here. There is bilateral occlusion of the SVC and the brachiocephalic vein on the either sides. This is how the catheter is parked into the SVC on either sides, and we stent that patient after doing a thrombolysis balloon plasty, and this is how the balloon is inflated, so that there is a space for the stent to be carried out, and this is how the stent is placed. So this is post stenting. What we see, there is good flow of contrast on the either sides. Another thing is ports, port placement. So this is the tunnel Hickman catheter. So these are tunnel catheters, and these are non-tunnel catheters. If the chemotherapy or the transfusion needs to be given, then this can be, if it is for longer time, tunnel catheters are preferred over non-tunnel. Again, while giving chemotherapy, pre-chemotherapy, the port can be placed, and PICC line if it is for giving, if no other access site is available. When the patient is having malignant pleural effusion, retractable pleural effusion, patient needs to tap regularly. That is the time we can place Plurex catheter. So this is a Plurex catheter. Patient can go home with this catheter, and can be counseled that they don't have to come to hospital. They can be taught how to remove the sample. At least 1 liter of a sample can be easily collected, so that the patient's visit to the hospital reduces significantly. And these are generally terminal ill patients who do not want to come to hospital again and again, and that's where the Plurex catheter comes into play. And this is a pleural catheter. This is also one of the tunnel catheters which can be placed. Coming on to the non-vascular post-operative settings, whenever there is a collection, that is a drainage pigtail catheter can be placed for doing the drainage, be it in the mediastinum or be it in lung, can be carried out. So this is a lymphangiography. This is a post-operative patients. What we see here is the lipidol. We inject it into the inguinal lymph nodes, and these can be carried out. And after that, when we see the leak into either the mediastinum, this is when the glue embolization of the lymphatic ductal system carried out in the thoracic duct and in the cisterna chyli. Many times we place a PICC catheter or the port that gets broken off, and this is where it is lying into the pulmonary artery. What we see here is a pulmonary artery, and that's causing cardiac arrhythmias and things like that. And that is the time we retrieve those PICC catheters or port catheters which have been broken off, and this was one of the PICC which was broken off at the end, and this was carried out. Again, the surgeons many times would not be able to palpate the metastatic nodules either from CA lung or from colon. It would be difficult. That is the time where we place hook wire localization, and this is what the hook looks like, and we place it under the CT scan guidance, and this is the thick thick part, what is palpated by the surgeons. Endobronchial ultrasound, which has been already covered by Dr. Amit in a very concise way. Coming on to another palliative procedure is when patient is having metastatic bony lesions from the CA lung. They have a pain score and a collapse of the vertebra. That is the time we combine two procedures, that is RF ablation. So this is RF ablation. So the radiofrequency ablation, and then cementing those can be done. So these are again when we are doing lung ablation, we can easily do by microwave ablation or by a cryoablation, and many times there is bronchial compression, tracheobronchial compression. That is time we can place a stent into the trachea and relieve the obstructive symptoms, and this is how the obstructive symptoms are relieved. This is I have already covered. Coming on to take home message, IR can be curative and palliative intent. Curative in case of bronchial artery or in case of CA lung when patient is having massive hemoptysis. Ablation for primary lung tumors and for secondary lung metastasis. Pulmonary thrombolysis and thrombectomy. Palliative settings like SVC is stenting for superior mediastinal obstruction, ablation for pain control, vertebroplasty, and pleurex placement for malignant pleural effusion. Thank you.